Hi, I'm Umar Bashir and welcome to today's session of the Radiology Instructor. This is the part 2 of ankle radiographs for trauma. I will go through a systematic evaluation of ankle projections in this session. These are two commonly performed ankle projections. The one on the right is an AP view, the one on the left is a Mortise view taken in 15 to 20 degrees of internal rotation. So I'll start off with the difference between the two views. If you look here, there is an overlap between the talus and the lateral malleolus, creating a zone in this location. However, on the Mortise view, the lateral malleolus has been thrown off the talus due to internal rotation and a clear space can be seen. I will first review the AP view. I tend to look for an obvious fracture in the first go. Then I would search for more subtle injuries. Follow the contour of the bone all around. It should be sharply defined and smooth all the way. No evidence of a step or incongruity of the bone surfaces, no evidence of soft tissue swelling that could indicate an underlying injury. Then look at this joint space here. This is the tibial plafond, this is the talar dome. Both surfaces are parallel to each other. The space is quite uniform. Same thing happening in the medial part where there is a space between the medial malleolus and the surface of the talus. Again, parallel and congruent. No evidence of a talar fracture, no evidence of an osteochondral injury. The space in the joint has been coated about 3 to 4 millimeters superiorly and medially. This part is obscured. As I've already said, this is an AP projection. To evaluate this area, we look at the Mortise view, which shows this area quite nicely. So again, quite smooth, sharply defined. The space coated up to 5 millimeters. On the AP radiograph, have a look at this process. This is the lateral process of the talus. Sometimes a fracture can be seen here. This site is a typical location for avulsion fracture from extensor digitorum brevis insertion onto the calcaneum. And what you may see is a small sliver of a fragment lying in this location. Now let's concentrate on this line here. Can you see there's a bright vertical line? This is created by the cortical surface of the peroneal groove. What's happening is that the distal tibia is concave and a part of the cortical surface creates this bright line. The concavity of the distal tibia allows admission of the distal fibula and creates a joint called the distal tibiofibular syndesmosis. If we take a critical measurement, which is at the level of the tibial plafond, go a centimeter up and then measure the distance between the surface of the fibula to the linear hyperdensity that we've been talking about. This should be less than 6 millimeters. An increase in size would be suspicious for distal tibiofibular dissociation. So in summary, I've mentioned these two views, the AP and the Mortise view, and given you the difference between them. And the way to look at them is to evaluate for any obvious fracture. Look at the cortical surfaces for any subtle irregularities. Look at the soft tissues to see if there is any swelling. Make sure that the talar dome is intact and there is no osteochondral injury. Make sure the joint space around the talar dome and the surfaces of the talus, the medial and the lateral clear space, are even and congruent, measuring between 3 to 4 millimeters usually. Have a look at the distal tibiofibular syndesmosis. Make sure that the lateral process of the talus is intact. No calcaneal avulsion fracture seen here. And in this manner, most of the common injuries should be picked. And I hope that a serious injury is not missed. Radiographic evaluation of the ankle is never complete without the evaluation of the lateral film. I'll go through the anatomy quickly. The tibia, fibula, the malleoli overlapping the talus. The inferior projection is of the lateral malleolus. The medial malleolus lies slightly superiorly. The talar dome is nice and smooth. The talar neck is intact. A slight step between the talus and the navicular is acceptable. The calcaneus with its projections looks completely normal. The cuboid is intact. Base of the fifth metatarsal, a commonly fractured bone, should always be included on the lateral projection and assessed carefully. Let's look at the calcaneus, a commonly fractured bone with serious consequences if the fracture is missed. The bone is very well sharply defined all around. The architecture is normal, no obvious fracture seen. However, we would evaluate the bone further by measuring the Bowler's angle, and that can be done by looking at 3 points. This is the superior posterior margin of the calcaneal tuberosity. The second point is the superior tip of the posterior facet, and the third point is the anterior process of the calcaneus, and we take the most superior part of it. Draw a line through point 1 and 2. Draw another line through point 2 and 3 and measure this angle. And that should be around 30 degrees. When the angle is reduced, it suggests a burst fracture of the calcaneus. The anterior process of the calcaneus is also a common injury and can be missed. Usually there is a fracture across in this location. Obviously this is a normal case and the anterior process is intact. Also look for high density areas, lines which could represent stress fractures of the calcaneus. I've already mentioned the fifth metatarsal should be intact. A fracture at the base of the fifth metatarsal is a common injury and can be picked up on the ankle radiographs. A word or two about the soft tissues. In this normal radiograph, we can see that their fat planes are very clearly defined. So there's some foot muscles, a bit of fat pad around the heel, very nice and smooth. The insertion of the Achilles and a pre-Achilles triangle of fat, a low density area. Further soft tissue, fat planes seen in this area, all nice and smooth. They tend to be obscured whenever there is ankle swelling, and when they're obscured, look hard for underlying fracture. So in summary, on the lateral radiograph, do all the basics, have a look at everything, but particular review areas would include these sharply defined cortical surfaces of the tibia and fibula. Sometimes a fracture may be evident on this projection only. Talus and the talar neck, the navicular, cuboid, very important, base of the fifth metatarsal, anterior process of the calcaneus, the entire calcaneus itself, and the measurement of the Bowler's angle. I hope this helps.